all the doctors who have been viewers right now for the initiative of Lloyd Healthcare, which is called as Lloyd Journal Club. I think a warm welcome to all of you. Even today's, I think you know which are the top specialties we're going to have here to deliver the lecture. So before that, Lloyd Healthcare has taken this initiative to keep upgraded to all the SOPs on the latest scientific happenings from the top journal like NEJM, Lancet. So we are taking that and providing that scientific endeavor. Lloyd Healthcare has always been in forefront to take that kind of initiatives. This is actually a sixth edition program we have been conducting with top doctors like Ashwani Mehta. I think entire nation knows about him. What is the contribution he has been done into the cardiology field? And even equally, Parmilla ma'am has also been there, top endocrinologist across India. If I talk about in a diabetes field or endocrine field, I think there are a lot of publications you can able to see related to Parmilla ma'am. So before that, viewers, we want to show how exactly the Lloyd Healthcare is all about it. It has been into the operation of India. Hope my slides are visible. My slides are visible?
Yes, they are.
Okay. So Lloyd Healthcare has been operating in India. It is operated in India from last, I think, 2012. We have been operated in India. It is basically originated from southern part of belt. Now we are operating across India. So we are synergizing the value with medicine, even the healthcare practitioner like what we are having, and improving the quality of life of patients by providing the quality medications. I think just to inform you, we are 23rd if I talk about cardio-diabetic company. Majorly, we are into a cardio-diabetic, and currently we place in the Indian pharma market. If I talk only the cardio-diabetic market, we are 23rd. We are almost having 12 years of experience. We are crossing around 500 crore rupees of business, and more than 2,000 employees are working across the nation for Lloyd Healthcare. Coming back, recognition and rewards, we are within a short span of time, we are able to get the reward and recognition. Like first, we got it from Outlook Business Excellence Award in 2023 in a short span of time as in Company of the Year. Coming back, there are multiple awards in the year of 2021, 21, and 22 for different business excellence. If I talk about the top brands, even if I talk about the fastest growing company in cardiac segment. So that is our USPs, which we have been working in chronic segment, and that's the reason we are getting the reward and award recognition from the industry. Coming back, we not only in India. Secondly, if you talk about it, we are getting the reward from International Book of Honor, House of Commons, London. We got the recognition from them also as in Company of the Year in the year of 2024. So these are awards, nothing but to grow further and contribute to the society, even contribute to the doctors like you, where we are providing assistance in terms of scientific upgradation, even the quality medications. Coming back, I think 20,000 leading specialties are currently prescribing our products. They are trusting on us, and more than 1.5 crore patients have been taking my medications or our company's medications. That's a small brief from Lloyd Healthcare. Secondly, there are multiple corporate hospitals which are having our products, and there are multiple SCPs are writing the products. These are the top hospitals. If I talk about corporates in the Indian, they have been having the products of Lloyd Healthcare. Coming back, if I talk about online channels like Tata, Apollo, everybody is having the products. Number of chemists, if I talk about 120,000 chemist availability has been there. So there is no question in terms of the quality medication not getting reached to the patients. I think we have across presence, even corporate hospitals and the online channels also. That's a small brief about corporate. Lloyd has been there almost 12 years we're in the industry. So we thought about to always show the strength what Lloyd Healthcare has been having and quality medication which we are providing. Now we are quickly going. I'm just stopping it. Our medical team, Sanika, please give the introduction to our top specialties. First, I think go with Dr. Ashwani sir, and then later on we'll go to Parmilla ma'am. Over to you, Ms. Sanika.
So much, sir. A very good evening, warm welcome to everyone. So today we have Dr. Ashwani Mehta, who is going to take a bioscope on development and external validation of machine learning based model for predicting heart failure risk in type 2 diabetes. And we have sir with us. And it is a great privilege that Dr. Ashwani Mehta, who is MD/DM cardiologist, senior consultant professor at Gangaram Institute of Postgraduate Medical Education and Research. Sir is also a director at the Heart Failure Program and Research, Sir Gangaram Hospital, New Delhi. With his privilege, Sir has also presented more than 250 papers and publications in various journals and been a speaker at various conferences and various peer-reviewed journals. With this, sir has also contributed in various chapters of cardiology and also been editors in various magazines to give away the knowledge to the upcoming team members and the specialist doctors. With sir has been a part of various committees who have had guidelines to how to follow and how to take medication and guidelines during cardiologist treatment and cardiology. Sir has been an investigator for 45 major international landmark trials, which have set the standard for treatment for heart failure, antiplatelet agents, lipid lowering, and various metabolic diseases. Some of these therapies have also changed the practices in overall world. So, sir has been a part of Indian editorial board also of the Euro Interventional Journal. So, with this pleasure, sir, it is our pleasure that with so much knowledge, you are here to talk on a different topic, which is a bioscope, which will be great learning for the listeners for us today. So thank you so much, sir, that you have been a part of this session and you have taken ahead the session for us. Going ahead, we have the second speaker, who is Dr. Parmilla Kalra. Ma'am is MTDM endocrinology, as we all know. Ma'am is a professor and consultant endocrinology at the Ramaya Medical College and Memorial Hospital, Bangalore. Ma'am has done a fellowships in various areas, which is FACE, FRCP, FAMS, and FITS. Ma'am has a specific clinical interest in thyroid diseases, diabetes mellitus, and gender dysphoria. Ma'am, with her treatment and patient education, also is it has done 90 plus publications and has 32 book chapters to her name. Ma'am has also been President-elect Indian Thyroid Society, Executive Editor, and the Thyroid Research and Practice. And with this, Sir, Ma'am has also been awarded with various awards, which is A.V. Gandhi Award, AR State Award, and multiple Best Papers Awards for her contribution in research in diabetology and various related disorders. So thank you so much, ma'am, for accepting our invitation for today's journal club. And with this, I would like to hand over the session to our speaker for the day, first speaker for the day, Dr. Ashwani Mehta, to kindly go ahead with the bioscope. And with this, I would like to hand over this to Dr. Ashwani, sir. So requesting you to kindly, sir, share your slides. I will just stop share from here.
Sure. Thank you so much for the kind introduction. I would make a humble request that kindly switch off all the, keep your microphone on mute because there is a lot of background noise. And now it seems to be have gone. So I would like to thank Lloyds for giving me this opportunity and would also like to welcome everyone being the first speaker and also like to thank and welcome Dr. Kalra and for being gracious enough to also to let me give the first talk because I have another engagement after 9. So I'll be talking about heart failure risk stratification in type 2 diabetes, insights from a machine learning model. Now, this is a very complex topic, but I'll try and make it simple and I'll try and make it understandable. Now, why we are talking of this, that is what is the most important thing. We are talking of this because we know that patients of diabetes are at risk of developing heart failure. So we need to focus and we need to find out the ways to predict that which are the patients who are at risk. And why so? Because today we have wonderful medicines. We have SGLT2 inhibitors, we have drugs like ARNI, and we also have MRAs, both non-steroidal and steroidal. And also we have the newer incretin-based therapies, which are changing the way, not only the way we treat diabetes, but also the way we treat hypertension and also predominantly heart failure. So why I'm saying so? Because if we intervene early in diabetes and use appropriate drugs, probably we can reduce the heart failure risk and also improve the trajectory of these patients as far as outcomes is concerned. So heart failure as such in diabetes is very prevalent, and the number of studies have shown that the prevalence rate could be about 22%, and this is increasing. One, because our population is increasing, getting old also, and number two, because we are also getting more and more patients with diabetes and may I say so, a new word, diabesity. Diabetes and obesity, which contributes to heart failure. And in diabetes, one might get heart failure even if there are no traditional risk factors like hypertension, coronary artery disease, or a valvular heart disease. Diabetes itself is recognized as a direct or an independent risk factor for heart failure. And in many individuals with diabetes, heart failure may be the first clinical manifestation of the cardiovascular disease. And there was one study which was published from Netherlands and which showed that at any point of time, patients attending diabetes clinic, about 2/3 of them have some kind of heart failure, and many of them are not even aware. And if you use biomarkers, you might be able to pick up these patients. And among individuals with type 2 diabetes, each 1% increase in HbA1c increases the risk of heart failure as much as 39%. So diabetes and heart failure goes hand in hand. And also in patients of heart failure, there is increased incidence of diabetes. So there are a number of risk factors and mechanisms which cause cardiac dysfunction and subsequent heart failure. Like if you look in patients, they can have coronary artery disease, they can have a myocardial infarct, ischemia, they can have inflammation, and subsequently they can suffer a cardiac damage and have adverse cardiac remodeling, and which can lead to heart failure. And per se, what we know, diabetes directly also involves lots of other mechanisms which can increase heart failure other than ASCVD and the cardiac dysfunction. So today the question is that we have to treat patients earlier, and the classification of heart failure, as we know, starts with those today as stage A, those who are at risk, and stage B as those having subclinical heart failure. So why this has been proposed? Because the whole idea is to act early, and if we act early, then we can probably treat these patients well much early. So progression from at-risk stage A to subclinical heart failure B phenotypes, also along with the complementary clinical risk factors and cardio biomarkers, can predict. So there have been a number of risk scores for heart failure assessment in type 2 diabetes, which have been made, like WATCH-TM, TRS-HF, and also if we add these selective biomarkers like NT-proBNP or BNP or the troponin I, and predominantly be NT-proBNP, and then we can really pick up patients who can develop heart failure. And if you look here, various stages of stage B heart failure have also been proposed based on various biomarkers, based on structure, and based on function. So I might not like to go in detail for the sake of understanding. But the implications of coexisting diabetes and heart failure are there, because concurrence of both would increase the risk of all-cause mortality, hospital readmission, and also poor quality of life. And we know that frequent hospitalizations contribute to progressive physical deterioration, worsening of cardiac function, and reduced treatment adherence. So, accurate prediction of readmission risk in heart failure patients with diabetes is essential if we really want to effectively treat diabetes and further prevent heart failure. Why? Because we need to treat these patients earlier in trajectory to help them and improve their outcomes. And number two, so that we can allocate the relevant resources to high-risk patients so that the outcomes improve. And if you look, the most existing risk prediction models usually rely on single biomarker and traditional statistical approaches. And on one hand, they give you an information, but on the other hand, it limits their ability to capture non-linear interactions and various complex interactions among the various variables. Like if you look at inflammation and metabolic dysfunction, now this plays a central role. And at a cellular level, it could be because of myocardial injury, cardiomyocyte apoptosis, endothelial dysfunction, and all this would aggravate heart failure. And in patients of diabetes, hyperglycemia, hyperinsulinemia can also lead to this. And the inflammatory biomarkers, which have been related to show relation to the prognostic value, would also relate to this. Metabolic indices associated with cardiovascular risk also can be associated. So there is a need for machine learning models, the advanced models, as today is an era of automation and AI. So the whole idea of using machine learning models is that it would provide algorithms for predicting these patients, identifying the key predictors, and enhancing the risk stratification. So that is what is the whole focus of machine learning models. What do the common models look like? Now there are various, ways we do it. So one is the data source and cohorts. One can use the records from the electronic health records or registries, and also the insurance claims. And development of cohorts vary from a few thousand to more than 100,000 patients in big registries. And typical endpoint could be incident heart failure diagnosis, heart failure hospitalization, or surrogate markers like elevated NT-proBNP beyond a certain threshold. Now, algorithms are used for this, and also the future engineering could include demographic, diabetes-specific variables like duration of diabetes, HbA1c, prevalence of comorbidities like CAD, AF, CKD, and then also the lab values like eGFR, electrolytes, hemoglobin, vital measurements like BP, BMI, medications, diuretics, ARNI drugs, ACE inhibitors, SGLT2, and when available, also using the BNP or NT-proBNP. So one can look at a single variable and also look at the trend, that in what direction it is going. So this is something which can be applied. So a watch DM risk score, which is there, it's just giving you an overview. It was developed using machine learning approach to predict 5-year incident heart failure risk in individuals with type 2 diabetes. There's another risk score, TRS-HFDM, which is similar, and these two have been validated across various cohorts with a good model performance. And we know that most successful approaches combine feature selection and tree-based ensemble models. I'll not like to go in details of the statistical models, but would like to highlight that what drives it, what are the key drivers. Being a clinician and a cardiologist, I'd like to say that if the patient has prior CAD, eGFR, BNP and NT-proBNP levels, duration of diabetes, and indicators of volume status or ischemia are the key drivers which predict the heart failure risk and outcomes. And if you look at the variables of heart failure diabetes risk score, it's age, BMI, systolic BP, fasting plasma glucose, QRS duration, creatinine value, diastolic blood pressure, LDL-C cholesterol, HDL-C cholesterol, history of prior MI, history of prior CABG. So, and if you score them based on this, as you can see, based on all these variables, you can score it. And if the score is less than 7, the chances of getting heart failure risk is again very, very low. And if it is 10, it is average, and anything above 11 means increased risk. So this is a very simple and a nice way which has been used. And watch DM, it also has been looked at. So incident heart failure of 3.6% was seen in accord over a 5 years period of time. And it has been validated by various ways. And risk stratification has also been looked at. So if you look at the watch DM score, it has been validated, easy to use risk score for heart failure prediction in type 2 diabetes. It uses routine clinical lab and ECG variables, enables early identification of high risk patients, targeted monitoring and prevention, and also informed use of heart failure therapies like SGLT2. And we know that machine learning approaches provide superior heart failure risk prediction compared to the traditional models. So a study was conducted by Hu et al. And it was published in International Journal of Cardiology and recently. And what they really looked at, this study, it was aimed to develop and validate a machine learning based model incorporating the inflammatory and metabolic biomarkers to enhance the risk stratification. So study design was retrospective cohort analysis, and patients between January 2020 and February 2024 were taken in, and hospitalized heart failure patients with type 2 diabetes. And the whole sample size was 716, and data pertaining to training cohort, internal variation of 30%. And what were the various parameters which were taken in were the clinical parameters, inflammatory biomarkers, metabolic indices, performance assessment, dissemination, the discriminations of area under the curve, ROC, accuracy, reliability, and diagnostic performance, sensitivity, and specificity. So the risk and conclusions, the results which came out was that the best performing model was random forest algorithm, and the key predictors which were there were demographic factors, age, cardiac biomarkers, BNP, clinical severity, NYHA class, heart failure classification, metabolic risk, and triglyceride glucose body mass index analysis. This again had a correlation with this, and this study developed a machine learning based model integrating the inflammatory and metabolic biomarkers for predicting readmission in heart failure patients with type 2 diabetes. And this model also demonstrated a robust performance interpretability, showing potential as a supportive tool for early risk identification and personalized risk communication in the clinical setting. Now, for patients of diabetes and HFpEF, so watch DM score is there, and HFpEF is more difficult because it's a very heterogeneous syndrome with various entities labeled, and diabetes itself would mean a high risk in HFpEF. And watch DM score predicts heart failure risk in OPD patients with type 2 diabetes, but its prognostic value in HFpEF is still not known. So they did a study to evaluate whether watch DM predicts clinical outcomes in diabetic patients with HFpEF, and there were about 414 HFpEF patients. Diabetes prevalence was about 49%, and risk assessment was done by baseline watch DM score. And the results, as we can see, showed more concentric remodeling hypertrophy than non-diabetics. And each 1 point increase in watch DM score was associated with high risk of all-cause death, cardiovascular death, any hospitalization, heart failure hospitalization, and the predictive ability for incident cardiovascular death was seen as a best predictive ability. And also a lot of statistical correlations were seen, and especially the area under the curve was lower for all-cause death, any hospitalization, and heart failure hospitalizations. So to conclude, as a high-risk phenotype for heart failure diabetic HFpEF necessitates the early stratification and specific treatment. And this study is the first to demonstrate that WatchDM score predicts poor outcome in patients of HFpEF, and also the convenience may allow for a quick risk assessment in a busy clinical setting. So what it means is that we can use it in our day-to-day practice. So the risk model for heart failure hospitalization in type 2 diabetes was the whole idea of this study, and this was published by the Williams et al, and this was published in 2020. And the idea was to develop prediction model for type 2 diabetes at high risk for hospitalization for heart failure, EMR based study, and they used again age, coronary artery disease incidence, BUN, AF, HbA1c, albumin level, systolic blood pressure, kidney disease, smoking status, and the results showed that the heart failure incidence at 1 year was 0.3, 3 years 1.1, 5 years of 2. And this model of hospitalization for heart failure demonstrated a strong predictive capacity and may help in guiding the various therapeutic decisions, which was validated. And these models can change the clinical care, probably fill in the gaps of treatment, and would flag the concerns and would flag the high risk type 2 diabetes patients in the EHR who have higher BNP and would require much better targeted therapy, and also identify the targets who would improve with such therapies like SGLT2 inhibitor, for example. And also the population management can be done. The health system can utilize these machine learning risk scores to prioritize case reach and also monitoring of these patients. There are certain limitations also. The models trained in one health system or one country might not be applicable to another. And many key predictors like BNP, echocardiography may not be available for a large number of population, and like in rural India. And also, if you look at the outcome definitions, then heart failure endpoints may not be same. High BNP could be one of the endpoint, but might not be for some other. It could be death or it could be heart failure hospitalization. And the prospective impact has still not been looked at. But overall, it's a very interesting and very much scenario which is in offing, where we will be using machine learning models in patients with diseases and specifically in diabetes to predict heart failure. Thank you so much for your kind attention.
Thank you so much, sir, for a wonderful lecture, what you have been having it. I think we got the info, you have to leave. So there are two multiple questions that came up. I just shortlisted two, so we quickly can go to Parmilla ma'am is also waiting for the second interesting topic, which is related to the diabetes. Sir, the one question from Dr. Sunil is coming up, is from Mumbai only. Can I use a simple risk score like WatchDM in my clinic to identify diabetic patients at high risk of heart failure or hospitalization? And how should that influence my management or referral?
So this is a very good and a pertinent question. And I think the time has come that in India also we should start using, these risk scores in day-to-day practice, because what it will do is it will identify patients. And if your patient is at a higher risk, you can refer these patients for further specialized tests. Maybe, for example, you've done the echocardiography, and then you can refer this patient for further, like the GLS screening or do the biomarkers to further substratify. And if you think, just based on this score, that if it is high, you can refer it to a cardiologist and maybe start therapies like SGLT2 inhibitors, ARNI, much earlier. So this can work and can be done as a practical application. And I think it should be done.
Thank you so much, sir. I think he got the answer what you have been speaking about it, and he got the clarity also. Thank you, Dr. Sunil Jain, also for asking the question. So I'm taking a last one before going to ma'am. In a patient with type 2 diabetes who has not have a cardiac symptoms, but having a high HbA1c level and mild renal dysfunction. When should I suspect a subclinical heart failure or refer to the cardiologist?
Yeah, this is a very good question.
This is again from Indore, sir. Dr. Rakesh Jain was asked the question to you, sir.
So I would like to say that, if you look at heart failure, then heart failure is a clinical diagnosis. So if you examine the patient, find pedal edema, find evidence of heart failure like raised JVP, S3, patient is breathless. And if you think your patient has heart failure, then you can confirm it by using NT-proBNP. And if the patient is not in atrial fibrillation, then anything which is in a young patient, more than 3 to 500 would increase the chances of heart failure for surety. And patients more than 75 years, it should be at least more than 500 to 750. And in presence of AF, these levels can be even high to diagnose. Now, having said that, he also asked a question that if the patient had a renal dysfunction. Now, any patient who has a renal dysfunction, whether it is reduction in their EGFR or presence of any amount of proteinuria, even microalbuminuria, would increase the risk of heart failure manifold. And these are the patients who are going to have a much worse outcomes and a bad trajectory of their outcomes. So they need to be treated very, very aggressively. Any evidence of renal dysfunction, which he specifically asked, like reduction in EGFR or even microalbuminuria, needs to be treated very aggressively. And today we have wonderful drugs to do so. And we must use all of them and should hit it hard right in the beginning.
Great, sir. Thank you so much for giving that clarity. Even pro-BNP has been coming up aggressively right now. Wonderful talk, sir. I think the SCPs has got benefited the way you have been talked about Bioscope, what we have been thinking about to bring this kind of a topics, and through your mouth, I think always been great, sir. Nice to hear you, sir, and thank you so much for getting associated with Lloyd Healthcare for this such a scientific endeavor, not related to the brand, but just all about scientific endeavor, sir. Thank you so much for your time, valuable, which you have given to us, sir.
Thank you so much. I really appreciate your efforts, and also thank all the audience and everyone who've been part of this program.
Thank you so much, sir. Now, I think after a wonderful lecture from Dr. Ashwani, sir, we are going to next stalwart. I think everybody knows about her, and people are eager to hear Parmilla ma'am words. I think, ma'am, towards you to the second topic, what we have been looking after it. The dice is over to you, ma'am. Welcome.
Metabolic syndrome, because we know that all these things are interconnected. So we know that it's not that one is separate from the other. And one of the things which we have understood over a period of time in type 2 diabetes management is that diabetes is one thing. Along with that, we know that patients with pre-diabetes are also predisposed to multiple metabolic complications. And these patients may also have MASLD. So we have understood a bit that all the patients who come with metabolic syndrome, type 2 diabetes or pre-diabetes or dyslipidemia or obesity or are overweight need to be screened for MASLD. So we'll discuss like who to screen, when to screen, and how to treat them. Now we know that MASLD is very prevalent, not that it isn't, but it is quite under-recognized. So we hardly used to see it, though we always had the report of the patient which suggested that patient has fatty liver, but many a times not much attention was paid to it and the patients were just told that it is okay, we'll follow it up. But we have to understand that this is a very, very important part of the metabolic syndrome. And more so, it is important for patients with type 2 diabetes because 70% of the patients with type 2 diabetes have hepatic steatosis. A good number of them, approximately 15 to 20%, can have liver fibrosis by the time they are diagnosed because many times the attention is not paid to the stage when they present with liver hepatic steatosis and they progress on to fibrosis and overall, over a period of time, to cirrhosis as well in some of the cases, and also predisposes them to increased risk of hepatocellular carcinoma. Also, we know that if the patient has diabetes, it actually accelerates the disease progression. It causes more mortality. As I told you, they may progress on to fibrosis, to cirrhosis, and hepatocellular carcinoma, hepatic failure. And it is an independent risk factor for cardiovascular disease. So if a patient has MASLD, it amplifies the cardiovascular risk many-fold. And we know that many a time this is not paid much attention to. We previously used to call it NAFLD, but now we know it is called MASLD. But the definition was changed to MASLD, and then now we know that we also talk about MET-ALD because it is metabolic syndrome associated diseases, which we call as, or the patient who has liver dysfunction, metabolic syndrome associated. And we also know if a patient has alcohol-induced disease, then they should not be classified into the metabolic syndrome. But many of these patients may also have concurrent alcohol intake as well. But we also know that MAFLD was initially thought of in 2020 to give a positive diagnostic criteria, because NAFLD used to be a diagnosis of exclusion. So it used to say if you're not finding any other cause, any other reason, no viral infections, no alcohol, nothing, then we used to call it as NAFLD. But then it was changed to MAFLD to give it a positive diagnostic criteria. So we know that over a period of time, they said, no, let us call it metabolic syndrome associated liver dysfunction. And they came to the criteria with the consensus that should be called like that. And we also know now the exclusion-based definitions have been abundant, and we should not stigmatize the disease. So that's why the terminology has been changed. And we also know when we use the word metabolic syndrome or metabolic dysfunction associated, we are actually aligning it with metabolic syndrome and diabetes. And we also know that recognition by the non-hepatologist has improved after that. So when we talk about the metabolic syndrome associated steatotic liver disease, we know that this affects around more than 70% of the individuals with type 2. This is one of the most common chronic liver disease which we see. So we have a huge spectrum of this. And we also know that we can have metabolic dysfunction associated steatohepatitis, where the histological progression is common. And 30 to 35% of the patients who have features of metabolic dysfunction associated steatohepatitis have inflammation and hepatocellular injury. Also, we know that 15 to 38% of the patients with type 2 diabetes can have advanced liver cirrhosis or fibrosis, and this can be unrecognized in routine clinical practice many a times, and they are diagnosed late. So we also have to understand that type 2 diabetes itself accelerates the fibrotic process or the fibrotic progression. Also, the longitudinal biopsy studies are there, which have shown a 70% increased relative risk of fibrosis progression compared to patients who don't have diabetes, even after adjustment for confounders. Also, we know that advanced MASLD in diabetes is associated with a markedly increased risk of cirrhosis, hepatocellular carcinoma, liver failure, and liver-related mortality. This contributes to excess cardiovascular and all-cause mortality as well. And we also know, because of the rising prevalence and the disease severity, MASLD-related cirrhosis and MASH-associated hepatocellular carcinoma have also become one of the leading indications for liver transplant worldwide, particularly in patients who have long-standing type 2 diabetes. So that's also very important. So when we talk about MASLD, what we call as metabolic dysfunction-associated steatotic liver disease, we say that there is steatosis with one at least more than equal to one cardiometabolic risk factor. It can be prediabetes, it can be diabetes, it can be overweight, it can be obesity, it can be dyslipidemia, or the patient is already on lipid-lowering medication, or it can be hypertension, or the patient is already on BP-lowering medication. Then we say MET-ALD, where we say MASLD with increased alcohol intake, because previously when we used to say NAFLD, it was basically a diagnosis of exclusion. But they said, no, we should include patients who are having MASLD but taking alcohol, because we have a huge number of such patients also. So MASLD in the setting of increased alcohol consumption between 20 to 50 grams per day in women and 30 to 60 grams per day in men is called as MET-ALD, where we say MASLD with increased alcohol intake. Then we have another category, which is alcohol-associated liver disease, which is not associated with MASLD, but it is a separate entity, where we have steatosis in the setting of sustained increased alcohol consumption, more than 50 grams per day in women and more than 60 grams per day in men. Other causes of SLD, that is a steatotic liver disease, like we know cryptogenic, unknown, without cardiometabolic risk factor, or without excessive alcohol use. So these things we also need to understand. Now, as we understood that MASLD is very prevalent in patients with diabetes, affects around 37 to 50, can be even more. This is one of the manifestations, we can say, of insulin resistance and metabolic dysfunction. And people who have pre-diabetes have also 2.5-fold higher likelihood of MASLD and an 8-fold higher risk of clinically significant fibrosis as well. And they may have actually a 6-fold increased risk of advanced fibrosis. Also, we know that hepatic steatosis is just not a bystander phenomena. So it's actually contributes to hepatic insulin resistance. It accelerates the progression to overt type 2 through the increased hepatic glucose output and lipotoxicity. If a patient has obesity, visceral adiposity, prolonged insulin resistance, it actually amplifies the risk of disease progression from simple steatosis to fibrotic phenotypes, especially in individuals who have multiple cardiometabolic risk factors. Also, we know that patients with prediabetes, the disease evolution is frequently clinically silent. They may have normal liver enzymes without showing any much changes in the enzymes, but these patients may have steatohepatitis or fibrosis. So, liver enzymes are not the best diagnostic tool. We'll be talking about FIF4, and I'll let you know what are the screening tools which you can use in your OPD to get a really idea that this patient needs more aggressive testing. So pre-diabetes is also one of the therapeutic window during which we can identify these patients. We can try aggressive lifestyle and metabolic interventions, which can prevent the progression to type 2 also, as well as progression to advanced fibrosis and future liver failure and liver morbidity. Now, if you talk about the liver dysfunction or the MASLD in type 2, we know over 2/3 of the patients are affected. MASH can occur in approximately 1/3. Also, it is important to understand that advanced fibrosis occurs in up to 38%. Diabetes actually accelerates the fibrosis progression. Cirrhosis and hepatocellular carcinoma risk is increased, and MASLD drives the liver transplantation demand. So, what happens? There's insulin resistance, there's increased hyperglycemia, there is ASCVD, incident diabetes. Along with that, these patients may progress, they may have MASH, they may have hepatic fibrosis, cirrhosis, hepatocellular carcinoma. They may decompensate as well. So all these problems may exist in patients with diabetes and they are interconnected. When a patient has MASLD or liver disease, we know that this patient is having a higher risk of cardiovascular morbidity and mortality. Also, they have higher risk of chronic kidney disease. Extrahepatic malignancy risk is higher in such patients. Quality of life is also reduced. Fatigue is common. They may come with fatigue symptoms, and their mortality may be multi-system driven. And these patients may have other things associated. They may have some skin issues. PCOS patients may have MASLD. They may have patients with obviously type 2 we discussed. The other types of patients having cardiovascular disease may also have accompanying MASLD. How do we screen? So we know that obviously the best way to diagnose is biopsy, but biopsy cannot be done for everybody. So we have to screen, we have to decide, and most of the times do without biopsy the management. So what are the screening tools and how best we can use it? So why should we screen? Because this is one of the most robust and reproducible histological predictor of liver-related and all-cause mortality. Early stage liver fibrosis is biologically dynamic and reversible. So if you catch it on time, when timely lifestyle modification medications are used, you can actually revert it. Advanced fibrotic liver disease progresses in a clinically silent manner, and patients will remain asymptomatic until they develop cirrhosis or decompensated liver disease. Liver enzymes are not the best to risk stratify the patient. Fibrosis-focused screening strategy is important. So we can identify individuals who are at high risk for adverse hepatic and extrahepatic outcomes and who can benefit from your intensive therapy. So this is how we do this is how the screening approach should be. This is how it should be done in our patients. So who all should you screen? Any patient with prediabetes, diabetes, obesity, overweight, long-standing diabetes, poorly controlled diabetes, metabolic syndrome, dyslipidemia, multiple cardio-metabolic risk factors, hypertension, family history of liver disease, proactive screening is to be done. Whom you don't need to screen universally, you can have like older adults who have recent onset diabetes. It's not 100% mandatory criteria, but we should better screen. Monogenic diabetes, or if you have a cost effectiveness concern, then we can not do the screening, but it's a good idea to screen because there's no harm in screening. So we know that steatosis detection alone is insufficient. High pretest probability is assumed. So we have shifted the focus to fibrosis risk because we know that these patients can progress from steatosis to fibrosis to end-stage liver disease to hepatocellular failure. And we know that we have to understand that first we can see the routine laboratory parameters. So if you have a patient who already has come to you with liver enzyme derangement. That's the case where you have to definitely screen for all liver problems. But there are patients who will have normal liver enzymes, and a maximum number will have normal liver enzymes. So a very good score is a FIB-4 score. This is a ready-made available calculator which you can always use in your OPD. I use it for all my type 2 diabetes patients universally. It's not that I exclude any lean or obese or anybody. Any patient who walks into my OPD with a diagnosis of metabolic syndrome, pre-diabetes, type 2 diabetes, dyslipidemia, hypertension, obesity, overweight, for all we calculate a FIB-4. FIB-4 uses what? The patient's age, AST, ALT, and platelets. If you have a value which is less than 1.3, it excludes the advanced fibrosis. It has a high negative predictive value. It is low cost and scalable, and it is one of the very good screening tests and a follow-up test. If you have a patient where the FIB-4 is higher, those patients definitely need more further testing like fibroscans. Those patients need more extensive workup. If you have a value less than 1.3, you can follow up these patients with lifestyle and then see how the FIB-4 score is changing on subsequent visits. If you have an indeterminate, like if your patient has in-between values, then these patients may benefit from doing a fibroscan. But if you have less than 1.3, you can at least understand that this patient may not need very urgent intervention. So we have FIB-4, we know that we can have the elastography. So we know that first line is if it is more than 1.3, you need additional risk score stratification for such patients. This is the first line screening for clinically significant fibrosis. Then comes the liver imaging. And we know that if you have a LSM score more than 8 kilopascal, then suggest stage more than equal to F2, clinically significant fibrosis. If the score is more than 10, it suggests F3 or F4, that is advanced fibrosis. If the score is more than 15, then it actually suggests stage 4. This is a very good modality, but sometimes again, if your patient has too much of the fat or is very obese, sometimes this can be difficult and might have to be repeated with experienced hands. But LSM score more than 8, we know it is F2. LSM more than 10 is F3 or F4. And LSM more than 15 is stage 4, F4. Also, we know that there can be ELF score which can be used. So ELF score more than 9.8 suggests stage F3 or F4, that is advanced fibrosis. But this is a second line screening. So here you can score we can use or we can calculate by getting the 3 proteins which are linked to the liver fibrosis. So we know that we can have hyaluronic acid, amino terminal propeptide of type 3 collagen, and tissue inhibitor of metalloproteinase 1. So this can also help to identify the patients who are at a very high risk. So this is you can say a next line of screening. And more than 9.8 is F3 or F4, and ELF score more than 11.2 suggests the stage 4 cirrhosis, that is of cirrhosis. So we know that best thing is do a fibroscan, and then you can do first you can do a FIB-4 score. If you have a patient whose FIB-4 is more than equal to 1.3, proceed with a fibroscan. So who are the patients who are at higher risk of progression to cirrhosis, type 2 diabetes, pre-diabetes, obesity with more than equal to 1 CV risk factors? So these are the patients who can definitely progress faster. Some patients may have a lower risk of progression. Some patients may have a higher risk of progression. So these are the categories, especially if the patient is gaining weight. If the patient has also concomitant alcohol intake, these patients need more aggressive management. So if you have a patient who FIB-4 is normal, you can follow it up, optimize the lifestyle and treatment of comorbidities. But if you have a FIB-4 which is crossing more than equal to 1.3 and is a higher risk of fibrosis, then you do the fibroscan. If it is more than equal to 8, as I told you, F2, then you definitely have to, again, follow up this patient, start lifestyle and think about pharmacotherapy. But if your FIB-4 score is more than 2.67, then you know this patient has a very high risk of fibrosis. So 1.3 to 2.67 is a category where we are managing with doing a fibroscan and doing lifestyle pharmacotherapy. But once you are crossing the 2.67, this has to be referred to the specialist. So we know that in the absence of this the LSM score, we can also do the blood-based ELF test, which I told you. If it is more than equal to 9.8, it is a good idea. We can do it these scores, and we can do this test, and we can refer to a liver specialist, as there is a high risk of MASH with advanced liver fibrosis. So this is also another category of patients. Now, what do we do? we diagnose a patient, we say, okay, your FIB-4 score is higher. You are at a higher risk of progression to advanced fibrosis. You are at a higher risk of progression to cirrhosis. What to do? So we have to first encourage weight loss. That's for sure. Calorie deficit is going to promote the weight loss. More than 5% reduction reduces steatosis. 7 to 10% reverses steatohepatitis and liver fibrosis. Nutritional advice, medical nutrition therapy, definitely. Support behaviors for diabetes management, address lifestyle. Now we know that drugs like GLP-1 analogs and other drugs are available, SGLT2 inhibitors, which are good drugs, which have shown beneficial effect in MASLD as well. Physical activity, more than 150 minutes per week is important, but the more the better. And resistance training is also important. Alcohol intake should be definitely stopped, because in these patients who are having MASLD already, we should preferably tell them to stop alcohol. Promote stress reduction via positive health behaviors. Screen for depression and anxiety and other things also. Adequate sleep is important. Sleep hygiene is important. And quitting the smoking also is very, very important. We have to tell the patient to adopt a healthy lifestyle. Patients who have MASLD with F0 to F1 obesity, if they have, they need pharmacotherapy. GLP-1 receptor agonist or dual GLP-1 GIP may be best option. We can give the benefit of SGLT2 as well. If a patient is gaining too much of weight, then the ADA 2026 also recommend that in obesity patients, you can actually give a combination of GLP-1 and pioglitazone, because pioglitazone may cause some amount of weight gain, which will be mitigated by the GLP-1. But if you have a patient with F2, F3, again, the treatment modalities are almost similar, but we can also offer resmetirom. And we also know that we should also be very, very careful that these patients should be counseled about weight loss, lifestyle modification. And when they have decompensated cirrhosis, then only insulin is the treatment for diabetes. But for obesity, we may not do much management because that cannot be reverted. But till F2 to F3, we can still think about reverting and talking to the patient and seeing if benefit is happening. But we should try to intervene from F0 to F3 stage. By the time we have reached the stage of cirrhosis or decompensated cirrhosis, not much of options are there for the patient except the transplant. So when we talk about pharmacotherapy, semaglutide is one of the beneficial drugs which has been shown to be beneficial not only in steatohepatitis or hepatic steatosis, also in fibrosis regression, reduction of fibrosis progression. ASCVD risk is reduced, CKD risk is reduced, heart failure, has been shown to have some benefit. Potential benefit has been seen with tirzepatide as well for hepatic steatosis, for steatohepatitis, for fibrosis regression, as well as reduction of fibrosis progression. Pioglitazone again has been shown to be beneficial. SGLT2 inhibitors have a potential benefit at the stage of hepatic steatosis. Other stages still questionable. Metformin can be an add-on therapy, has not shown much effect, but not much data, but we know that can be one of the good drugs to offer along with the other drugs. DPP-4 inhibitors are again neutral. Insulin may have a potential benefit by reducing the inflammation, reducing the hyperglycemia and progression to some extent. Sulfonylureas have a neutral role. So the patient who has diabetes with MASLD needs a multidisciplinary care. It has to be definitely lifestyle and weight loss for sure. Along with that, pharmacotherapy is a treatment as per the ADA standards of care. We should offer these patients GLP-1, SGLT2 if they have diabetes, and pioglitazone can be given along with GLP-1 for MASH. CV risk reduction also has to be taken care of. We have to treat the dyslipidemia. We have to treat the hypertension as well. If a patient has a FIB-4 score which is normal, less than 1.3 today, we need to follow up the FIB-4 at least 6 months to 1 year once. That's a calculation you can always do. And if we have a patient who has FIB-4 more than 1.3, definitely we should send the patient for fibroscan. Also, we have to see that if a patient has already come to you with F2 to F3, then these patients need a referral to the hepatologist. These patients definitely will benefit again from GLP-1 or dual GLP, GIP. And we should also think again about CV risk reduction in these patients. And if you have a patient who's already manifested with cirrhosis, then we don't have much of things to offer. We have to treat the cirrhosis. We have to also take care of the diabetes. And mostly in such patients, if it's decompensated, we have to mostly give insulin. And these patients do well. And resmetirom cannot be used at this stage. But definitely at F2 to F3, we can definitely think about resmetirom as well. So when we talk about metabolic dysfunction associated steatotic liver disease, it's very prevalent, quite common, seen in all patients who come with metabolic syndrome commonly, but not like it is very common for all. But with type 2 diabetes can be up to the tune of 50 to 60 to 70%, can be one of the significant complications which can be neglected. The best thing we can do in the OPD is do a FIF4 score. You need a platelet count, you need SGPTOT and the age of the patient. If it's less than 1.3, repeat every 6 months to 1 year the calculation only. You can calculate it by the simple lab parameters. If it's more than 2.67, you refer definitely, and those patients need aggressive management. Between 1.3 to 2.67, you can do a fibroscan, see the LSM scores, and take a decision. And we know that intervening early with pharmacotherapy may be the treatment, especially if the patient is overweight, obese, has diabetes, has a high risk of progression. Because if you intervene at the right time, it is better rather than intervening later when the patient has already developed cirrhosis, because then it may not be very beneficial. Thank you.
Thank you so much, ma'am. A wonderful lecture from your side. As always, been clear and crisp to the people who are listening to you. I think that's the MSLD. I think it has been top notch. Has been coming up as an treatment approach. Ma'am, we have a questions. Definitely, we're gonna throw to you, ma'am. Just I noted some questions here. I shortlisted.
Please.
The first question is from Dr. Krishna Prasad from Vijayawada,
Yeah.
ma'am. While choosing antidiabetic therapy for patients with MASLD,
Right.
how should
Right.
a doctor prioritize oral agents such as metformin, DP4 inhibitors, or SGLT2 inhibitors to improve the glycemic control without worsening the liver health? That's what the
Yeah.
question from him.
Yeah. So as I already told, that drugs like metformin, and if you talk about DPP4 or SUs, they are mostly neutral for this. But when you talk about the use of drugs like GLP-1 analogs or SGLT2 inhibitors, they actually help for weight loss as well. And I already showed you the slide where I showed you clearly that 5%, 7.5, and 10% is the weight loss which we are targeting when we are trying to take care of the steatosis or the fibrosis progression reduction. So for those type of indications, if you have a patient with type 2 who is overweight or obese, they will best get treated by giving medications like GLP-1 and SGLT2, which I'm talking about a patient who has MASLD and is overweight and obese and has type 2 diabetes. So those patients will definitely benefit by giving drugs which help in weight loss, which have shown some benefit. SGLT2 have been mostly showing benefit in the studies with the steatosis component. But if you see, the data has come with semaglutide over the fibrosis reduction. So that's the stage where you definitely need to offer. You need to see what is the FIF4 score, what is your patient's risk of progression to fibrosis. And then if a patient is overweight or obese, there's no harm in offering drugs like SGLT2 and GLP-1s, which can help in weight loss as well, control the diabetes as well, give a cardio-renal protection as well, and take care of the MASLD. DPP4 inhibitors can be used, yes, but they are weight neutral. They are neutral for steatohepatitis, you can say, or MASLD. So can be used but GLP-1 should be offered rather than the DPP4. Metformin can still be used. Metformin is obviously the first drug, and then you can add on a GLP-1 and a SGLT2 alongside with that. That's the best you can give for a patient, especially for type 2 who are overweight, obese, and have MASLD, especially if their FIF4 score is higher. If their FIF4 score is lower, you can give even metformin, DPP4, but you have to understand that these are weight neutral drugs. So you don't expect a weight loss with these drugs. So if you are targeting weight loss in a patient who's overweight or obese, it's a good idea to give benefit of SGLT2 and GLP-1s.
I think majorly he's looking about GLP-1, ma'am. I think that's the most, I think he's looking for that answer. I
Absolutely.
think you have given that
Absolutely.
answer, ma'am.
Because the amount of weight loss which happens with GLP-1s is much higher. And the average weight loss which you see with SGLT2 is 2.2 kgs. With GLP-1s, we can have 6%, 10%, 14%, 15%, now we have 22%. So we are talking about percentage weight loss. And that's why GLP-1s score over SGLT2. And we have data with semaglutide, which has come up from the Essence trial for liver fibrosis reduction as well.
Perfectly said, ma'am. Now from South, we are moving to North also. I'm taking a question from North. Dr. Kuldeep Kapoor has been there, ma'am. With increasing patient demand for GLP-1 injectables influenced by social media, I think that's related to this, ma'am. How should a GP consult the patients who are well controlled and oral agents like metformin, DPP4, SGLT2 inhibitors? And when is it reasonable to continue or optimize oral therapy instead of escalating to the injectables? I think he's looking from the scenario of patent loss of semaglutide injections are bombarding the market, ma'am. I think from that angle he has put the question.
Yeah. So when we are talking about the use of GLP-1, we don't put it at the next therapy. GLP-1 can be offered even as the first line if your patient has high risk for ASCVD, renal disease. So according to the guidelines, we can offer it even as the first choice. It's not that injectables are only after the oral. Especially if I have a patient who is having type 2, is overweight or obese, I would definitely give the benefit of GLP-1 to my patient rather than a DPP-4 inhibitor in the beginning itself. If I have a patient like who has MASLD, I will definitely give the benefit of GLP-1 rather than giving a DPP-4. If I have a patient where I'm trying to get the patient lose weight, I'm going to give the benefit of GLP-1. If I have a patient who is trying or who is high risk for ASCVD or renal disease, I'm going to give the benefit of GLP-1. So these are all the categories of patient where you can give. So even if you have a patient who is overweight or obese and is on DPP-4 inhibitors and is doing well, you can always substitute the DPP-4 with the GLP-1. And giving an injectable GLP-1 is not a progression of therapy. It's a beneficial therapy which you are giving to the patient, which will help in weight loss, cardio-renal protection, as well as the further protection of MASLD and progression to fibrosis as well.
Thank you, ma'am. I'm just taking a last question right now from the western part of India. It is from Dr. Kapil Patil from Amravati. Ma'am, in patient with type 2 diabetes, he is actually a GP, ma'am. So that's what I'm asking. The question is from that category. In patient with type 2 diabetes and obesity, when should a GP actively suspect and screen for MASLD? And which simple investigations can be used at a primary care level before referring into it?
Yeah, very good question. So it's important, as I told you, all patients with type 2 diabetes who are overweight or obese, you should suspect MASLD. That's first answer. Every patient you should suspect. Just do a simple FIB-4 score. FIB-4 score is a ready calculator available online. You just need a SGP-OT and age of the patient and the platelet count to calculate the FIB-4. So if your FIB-4 score is less than 1.3, this patient is not absolutely at a high risk of fibrosis, and this patient you can follow up. But if your FIB-4 score has crossed 1.3 and is less than 2.67, this patient definitely needs a fibroscan. But in case your FIB-4 score has crossed 2.67, then you need a referral to the hepatologist. So that is one ready-made thing I can tell you. But again, you have to be cautious if somebody has low platelet count. So in that patient, you might not be able to calculate the correct FIB-4 score. So that's another category. But overall, you can take this. A FIB-4 score calculation at every OPD visit with an online calculator free of cost is the best thing to do.
Absolutely rightly pointed, ma'am. Any patient diabetes, we need to keep a watch on liver health. That's a perfectly said. And wonderful, ma'am, to hear you. I think a lot of comments has been coming up, been important updated session from both of you, ma'am. And has always been great to hear you from you, ma'am. So we are just ending up right now, handing over to Ms. Jyoti Singh for the vote of thanks, ma'am. Over to you, Jyoti.
Yes. So on behalf of Lloyd Healthcare, I would like to extend my sincere gratitude to everyone present here today. First and foremost, a heartfelt thank you to our esteemed speakers, Dr. Ashwani Mehta sir and Dr. Parmilla Kalra ma'am, for sharing their thoughts on the topic. Your knowledge, clarity, and practical perspectives have truly enriched this session and added immense value to all of us. We deeply appreciate the time and effort you have taken to be with us and guide us today. Thank you so much, ma'am and sir. I would also like to thank our audience, the doctors who have participated from across India in huge number for this session. Your presence and interaction have made this session meaningful and successful. A special note of appreciation to the organizing and field teams whose dedication and coordination ensured the smooth execution of this program. Once again, thank you to each and everyone for being a part of today's event. We look forward for your continued support and association with us in the future. Thank you so much, ma'am.
Thank you so much, ma'am. Have a good night and wonderful night.
Thank you. Thanks, everybody. Good night to
everyone. Please shut down the live screening. And ma'am, the number count is 2,500, ma'am.
Okay, great.
Yeah. Thank you so much, ma'am. Have a good night.
Okay.